Oh, there's people waiting in the lobby now. I can start
Okay.
people are starting to join now. Just one sec. Yeah, we got some people.
Okay.
Someone's messaging that is nice to see you, Raj.
All right.
Yeah, it is. I'm recording. Yeah.
Okay. Fine. Let me just upload now. There we go. Why is my PowerPoint not coming up? Here it is, right? Okay. Okay, can you see PowerPoint now?
Yes, we can.
Okay. Fine. Well, hi everybody. Thanks for joining in. I was just going to do a quick run through about hemorrhage in the head and neck, and it's more for basically to divide it into whether it's traumatic or cancer related, really. All right. I see we have Becky here, Becky Wyatt. Thanks for coming, Becky, because it's good from the sort of in the field point of view how you all manage head and neck hemorrhage and comparing it to what is actually done in hospital. All right. So I thought we start about talking about a case, and that's the best way to move forward. So we have this gentleman who was in the field in the army, and he basically got a gunshot wound to the right side of his neck. Um, if you were out, let's just say the patient was in the, just in the public and had a wound or a trauma to the neck, what would anybody suggest? How would we start managing this patient? Anybody at all? Anybody know about any guidelines about managing patients who have bleeding from their neck?
I don't really know any guidelines, but I guess you will try to stop any bleeding. There is a way to.
Yes, but
It's
does anybody know? Like, it's basically this is part of what your syllabus and entails. So you need to know what the guideline is. Anybody has any chance or any courses that they may have attended that teaches you how to deal with hemorrhage? No? Everybody shy? All right. So, I mean, it's ATLS guidelines, right? Now, ATLS guidelines, the Advanced Trauma and Life Support, basically apply to any sort of trauma that happens from tip of your head to, nails on your toes. And what they've done basically is their response to resuscitating patients is a bit different compared to advanced life support guidelines. Um, so normally where we say A, B, C, D, airway, breathing, circulation, and then disability, they tend to start with C, A, B, C, D. And that's what this gentleman in the picture is doing. It's compression. All right. So anytime anybody has any massive trauma or massive bleeding from the neck, especially, the first thing you want to do is apply compression. It can be in the form of gauze, and if the patient is in A&E, you can actually put on a pair of gloves, apply direct pressure to the area that's bleeding with your hands. The other option is, which I think one of our colleagues actually had done, is just to stick a Foley's catheter into the open wound and inflate the catheter, then withdraw it, which is basically like what we do for posterior nasal bleed. And then the question is, what do we do? Do we get this patient into the scanner or do we get the patient straight to theater? Again, so does anybody know when we would do what? So let's say your registrar or one of the registrars are busy in theater and one of the SHOs has basically seen a patient who's in A&E resus, bleeding from a penetrating wound to the neck. What would you do at that point? I don't want to call on people, but who else is here? Let's see. Becky, what would you do? Would you take the patient into the scanner with a bleeding wound from the neck, or would you take them straight to theater? You're on mute, I think.
Oh, it's because you've got the.
I can hear you. We can hear you now.
She's saying that we can take him straight to theatre. Yeah.
Okay, Khalil, why? I think we're on a lot of feedback, so somebody needs to turn off. Yeah, right. So Khalil, why would you take the patient to theater and not to the scanner?
I don't think it's gonna be safe.
Oh, yeah, you both have your mic on, that's why. Yeah, well, when you say it's not going to be safe, what you mean?
So from like from an we don't know if there's an airway compromise or things like that. So
Man is screaming in pain.
sorry.
He's screaming in pain.
Okay, so the patient is in too much pain, and we don't know if there is any, like, for example, you said like he's bleeding, and you're trying to stop this bleeding. So hemodynamically unstable, unsure about the airway, it would be very unsafe to take him into the scan in such state.
Would you say that you're unsure about the airway?
Say again, sorry. No, if he's screaming in pain, then the airways are fine. He's screaming.
So then
So
what's your reason then to take him to theater directly?
hemodynamic instability, active bleeding, open wound, all of this is
So if he had an open wound and he wasn't actively bleeding, would you take him to theater or would you take him to the scanner?
theatre.
He's not actively bleeding, and you just said if actively bleeding, then you take him to the scanner.
Okay.
Well, in real life, this is what
So,
happens, right? They come in with a wound to the neck, and it's most of the time it has stopped bleeding by the time it comes to us because the
It could
paramedic.
start bleeding in the scanner. That's the thing. I mean, I don't know the guidelines. I'm here to learn, but I'm
Good,
just trying to rationalize
that's
uh,
it.
because it could
yeah.
bleed again in the scanner, and this patient could
Correct.
die. Yeah.
Correct. So that's very good. That's the correct answer. So the thing is, there are guidelines about when to take a patient into scan, and this is extremely important. This is our Bible. This paper that was published by the Royal College of Surgeons,
Okay.
it has hard science and soft science about when to take a patient to theater, when not to take a patient to theater. So you're absolutely correct. So active bleeding from a wound is one. Hemodynamic instability, swallowing difficulty, airway compromise in terms of voice changes, stridor, shortness of breath, crepitus, all these sort of things um, are hard signs which you have to take into consideration when you're deciding whether to take the patient into theater or not. So I would definitely just take a screenshot or just take a picture on your phone. This paper, you have to know it. It's just one little box and it has all the answers in it about when to take a patient to theater, when not to take them. All right. It is part of the FRCS syllabus and you have to know it inside out. So it's a really, really good one. Okay.
Thank you.
So,
Noted.
yep, good. Now, so we take this patient to theater, and what do we do now? Is there any way, like Osama, do you know any way we can? What are we going to do for this patient?
So, as you said, first we're going to compress on the site of the bleeding, then following ABC and to see if there is any hard signs that needs to take him direct to theater. So I'm assuming we already take the decision to take him to theater.
Mm.
So we have to determine which zone is injured. So to determine which specialities we need actually with us,
So does
because it
zone,
depends on the site of the trauma.
so does zone and site of trauma affect your decision making?
Um, it's also about general situation, if the airway is impaired or there is an active bleeding right now.
Okay.
So,
So zones, so this is one thing that we want to clarify. So there's three different zones that you have in the neck or levels, right? So
yeah.
zone 1, 2, and 3, which starts from the clavicle all the way up to the skull base, right? And zones are more used to describe something over the phone to your consultant or to the radiologist to indicate where your area of penetration is. But it does not offer any prognosis for the patient. The reason is because trajectory of your penetrating wound can be quite different. If it's a knife, it's the direction in which the blade has entered, the forces which has entered.
Mhm.
Because you can enter at a zone 1 but have all zone 3 injuries. So it doesn't help you with your surgical planning or your team assessment. All it does is just helps in describing your entry point, which is why it's good to know the paper that we've talked about before. So it tells you when to go to theater, when not to go to theater. But the zoning issue doesn't help you with your actual management plan of the patient. So that was the intent of the paper, but they found in actual practice, the evidence says that using zones does not help you with your surgical planning or your management of the patient. It's more or less the hard sign and soft signs, right?
Mm.
So you go in and there's, as Khalil was alluding to, there's three major things that you're going to be thinking about that's going to be injured. One is your airway, so your trachea.
Yeah.
Two is your carotid sheath, which is either your, your jug or your carotid, um, your, your carotid artery, and then 3 is your esophagus, right? But today we more want to be concentrating on the bleeding aspect. So with regard to this, so this is just an open picture of a neck, is obviously during a neck dissection, showing your internal jug, and then your carotid has been hidden underneath. Um, Basically, you want to open up your carotid sheath on the side of which you've had the injury, all right, if there's active bleeding. The most common vessel that will bleed from a penetrating injury is usually external jug, which is quite superficial. Just as you get through the platysma, you will see the external jug as you're cutting down. You will see it then. You will know if there's an injury. You can tie it off under direct vision, which is what we can do in A&E. But once you realize something deeper, you have to open up your carotid sheath. And then the first thing you want to do is control your bleeding, apply swabs, direct pressure to the area. Then you look at your jug, which is most anterior. You see if there's any bleeding point supported. You can either tie off the jug above and below the bleeding point, or you can put a stitch through the actual bleeding point. It depends on the size of the wound. Usually, if it's less than 3 millimeters, you can get away with just putting a stitch through the hole. If it's more than that, you need to tie off your jug. That's the recommendation. But if it's an arterial bleed, then this is where we run into difficulty. And then you have to start exploring where along the entire external carotid artery that you have this injury. Ideally, you want to have a bleed above the superior thyroid, because then if you're tying off below the superior thyroid artery, you can end up causing necrosis of the ipsilateral thyroid gland. So once you've opened up onto your carotid artery, you have to try and explore and see which branches are there, where the level of injury is. And does anybody know how we find the carotid artery? Is there any landmarks we can use? So we're going into a neck, right? You're in A&E and
Posterior belly of digastric.
Yep. So you just look. So that's why this is here. So you look for your posterior belly of digastric, and just posterior to that will be your carotid sheath, which is where your carotid artery will be. All right. So it's nice and clean in a nice neck dissection. But when you have blood pooling and pouring everywhere, what we tend to do is we pack. You just pack the neck. Okay. So you pack in all quadrants. You pack um, lateral, superior, lateral, inferior, and then in between the carotid sheath and the trachea, you pack there as well. So superior and inferior, and you're just basically trying to pack your wound, get bleeding under control, and then try to find where your blood vessel is. Okay. The main thing you have to know for the exam point of view is where you're tying off. So when you have a trauma bleed, you'll end up having to tie off the entire external carotid, and then may have to end up doing a a hemithyroidectomy in that case, because you've knocked off your blood supply to the um, thyroid gland on that side. Ideally, you want to tie off above lingual and facial, because if there's bleeding further up, then you can get away. But that's what we do when we have a cancer bleed. So if you're doing a cancer bleed, you try to avoid superior thyroid, and you tie off just above superior thyroid, because the cancer bleeds tend to be oropharyngeal bleeds, and you want to take off facial and lingual. If you have enough time and you're good enough, you can dissect out lingual, dissect out facial, and tie both off individually. So in entry for cancer bleeds, they would dissect out these. And notice here, they tie off just the external carotid from here. So Khalil, what do you think is going to happen though if we tie off the external carotid artery? What's going to be the big issue with that? And let's say we've saved superior thyroid. What's going to happen with the rest of the branches?
Usually it takes the support from the other sides. It won't be a great issue if you have the other external carotid is fine.
Yeah, that's correct. So you have to make sure that the patient has a good, and is there any way to know whether they have a good external carotid?
Not sure.
Feel the pulsation of the superficial temporal artery.
Yeah, that's right. Yeah, you can feel it. But then the question is, so you feel the superficial temporal artery. That gives you a good idea. All right. But again, we're talking about a life-saving situation here. Yeah. So they can end up with palsies and, quite significant end artery injury from ischemia, but at least they'll be alive to suffer through that. Yeah. So in that situation, we can't, that's why you won't routinely find somebody palpating the contralateral superficial temporal artery, because at that point it becomes life-saving. So you tie off and you deal with the issues later on. Okay.
Yeah.
So the next question leads to what else can we do then? If we can't, let's just say this patient is a post radiotherapy, we can't get into the neck is quite, flexed. It's difficult to intubate. Is there anything we can do besides tying off?
On the
Actively
table,
bleeding.
I would just back it and close it. I don't
And,
know.
and hope for the bleeding to stop. It will stop eventually because they'll be dead.
I would engage the interventional radiologist
Correct.
in
So that's the
such
next answer.
difficult
Correct.
case like that.
I mean, on
Yeah.
the table, I was saying, I was like, if the patient is on the table, you can't get access to the vessels. It's still bleeding. What would you do?
Yeah, but you can pack it, which is what you said, but then what you're going to do, that's the whole point. You pack it and what? Pray to God. You hope for the best. It's going to continue bleeding. They will bleed to death. You need to have a plan in place. That's what you have to be thinking 2 steps ahead with trauma patients, right? And that's the whole point of the talk. So that's the answer for the exam, and that's what the examiner will ask you. So you're correct. Your first part of the answer is correct. You pack the wound, put pressure on it, and then what?
then
You get
get the
as Osama said,
get the
yes,
radiologist. The
interventional
radiologist.
radiologists. Yeah, good. And what do they do? What do interventional radiologists do?
So are they gonna go just go with a wire to try and source the bleeding, or do what angiography to sort to see where the bleeding is and to try and locate it first
Good
before.
answer. Very good answer. So Osama, you'll be able to help us with this part. So how would they know where the bleeding is? What do they look for?
So they are going to identify where is the site of extravasation of the contrast, then plug
So what that,
it.
yes, so what's that called? How do they know where the extravasation is? There's a particular term. There's a term for it. That's why I'm saying this is what you need to say
Yeah,
it
yeah,
to
I
yourself.
remember, but I'm not remember the name
It's
of this
okay.
term.
So it's
Just
called
looking
the
for the
blush
extravasation
effect.
of the contrast and then plug it.
Yes.
So, but
Correct, correct. So
that's the
it
name.
is, that's the description. It's called the blush effect. So you'll see a blush of contrast will just pop straight through where the area of injury is. And it's called the blush effect. So they look for the blush sign. And once they see that sign, they know where the level of injury is. And as Khalil was correctly saying, you can put a coil in, right, in order to increase thrombosis in that area, and it eventually will occlude off. But the interventional radiologists are really particular and they're really concerned that when they do that, they tend to do it at the level of the carotid because they can't specifically put the coil exactly where they need to put it. So they tend to put it before the bifurcation. And then once you do that, patient is at high risk of stroking out. So they always ask, is there any way that we can do it surgically before they get involved in intervention? And that's why you find you can get away with cancer patients getting them interventional radiology involved for them. But with a penetrating neck trauma, healthy patient, we should be aiming to get that patient in the theater and tie it off. All right. And just to add basically on to this, just this is a final point. There's a nice website, the Aintree Head and Neck website, right? And let me see if I could pull it up. It is a really good website. It has a video on how to tie off the ECA. Head and neck. I just want to show you the videos. It is worthwhile because they have tons of videos on there about head and neck. They have how to do, this is the website here, the educational videos, the Liverpool Head and Neck Center, and they have tons of videos on here. So it's worthwhile watching, and it is based in the UK, obviously, and what we tend to do. Yeah, so you can see, where's the head and neck? Professionals. Can't find the head and neck now, but there's a whole lot of head and neck stuff. I don't know where they're gone. So, like, this is more for the practicality side. I don't know why it's not showing up. Surgical videos, yeah.
I found it's in surgical videos under professional, and then head
Yeah.
and neck. There's a lot of videos there.
I don't know why the head and neck isn't coming up here. It normally supposed to continue to content. Here they are. Here it is. External carotid artery ligation. So this
Yeah.
is really good stuff. And this is how it is done. Well, you got to sign in and all of that. But this is how it is done in the UK. And they have, it's just a 2-minute video, basically. I would definitely advise everybody to have a look at this. And it has a lot of other things. It has how to rate flaps, how to do myotomies, how to do you call it, a neck dissection, transoral resection. This is a really, really good website, but definitely in the realm of what we're talking about today, the ECA ligation video is a good one to watch, and you'll understand what I was talking about, how they dissect out the vessels and they try to find lingual and facial and clip those two rather than just tying off the entire external carotid artery. All right, so that's just a quick talk. I hope it was a bit useful. It was just more to run through about, major, I'm sorry, principles of management and what is applicable for the exam. So in summary, you have to know the ATLS guidelines. And for major hemorrhage, it's compression, airway, breathing, circulation. You have to know about the table about types of shock, level 1, 2, 3, and 4. Right. And the main thing they want to know is that at level 3 and 4, that's when you have neurological changes with the patient where their GCS starts to drop. You have to know about the surgical intervention, which is what can be done surgically. So you have to pack your wound. If you can't pack the wound, you can tie off, do your ECA ligation. And if you're going to do ECA ligation, you're trying to aim above the superior thyroid artery. If it's for cancer, you're trying to just tie off lingual and facial arteries, right? And then the last thing, you have to know that paper about the hard signs and soft signs about which patient can go to theater directly, which patient can go to the scanner directly. And that's it. That's all you need to know about for head and neck hemorrhage from a neck point of view. Is that all right? So it's in a nutshell.
That was really helpful. Thank you so
Yeah.
much.
But definitely just look at the video and look at the paper. That's the two main things, and that will get you ready for the exam. That's all you need for the exam. The other things are more practicality aspects about the compression and interventional radiology. Those are more practicalities. Is that all right?
Yeah.
Thank you, Raj.
No
Another thing
problem.
that I think it will be beneficial to discuss about bleeding per tracheostomy. I think many of us, especially the junior doctors who are on site,
Yeah.
get a call about bleeding trachea. Some of them is insignificant, and others is maybe catastrophe things, like for these patients, palliative or for a carotid show or impending carotid blowout.
Yeah.
So if we can just give a short things about approach
Sure.
to such cases, because I think it's also more common, especially in the world.
Okay. So for trachea, that's true what Osama is saying. I think that's a big issue more with MRI rather than other hospitals, just because of the volume of tracheas that are being done, and the kind of complex patients that are being done there. So basically, when you have bleeding from a trachea, you have to decide whether is it from the trachea, because when you say bleeding from a trachea, is it from the actual tracheostomy? Is it from the tracheostoma? Is it from lower in the airway? Is it from upper in the airway? Right? That's the first thing you need to decide. Then once you've determined your location of bleed, how are you going to manage it? Is this a medical problem? Is this a surgical problem? If the patient is very anticoagulated, you medically manage them. All right. So you need to find out they need reversal of their anticoagulation. So you do your vitamin K, your fresh frozen plasma, or your reversal of warfarin products that you have to speak to the hematologist about. Okay. If that doesn't work, or if you have a situation where the airway is actually being compromised, then you need surgical intervention. So as if your medical management fails, or if there's airway compromise with your tracheal bleeding, then you need to take the patient into theater. That's your two criteria. Now, while you're prepping this patient to go to theater, you can't try to stem the bleeding. And there's different options. Again, there's medical options and surgical options. The first medical option is you pack the wound, you pack around the tracheostomy. Now, there's some evidence to say you pack it with tranexamic acid for what it's worth, for its topical effects. But if you have an active vessel that's bleeding, tranexamic acid is not going to help, unfortunately. You need to tie off the vessel at the end of the day. Some people try with adrenaline. Again, you have to be in contact with the bleeding surface if you're going to put adrenaline soaked gauze around the wound. This does help when you have minor oozes or there's a medical cause of the bleeding. If there's a surgical cause, meaning an open vessel or bleeding from muscle edges, you have to take the patient to theater. Then, so that will be from your SHO prepping the patient, and you make sure you get blood as backup, because these patients, what you're seeing is just the tip of the iceberg. Case in point, I had a patient when I was at Wythenshawe, had a slow ooze, they packed it and everything around the tracheostomy site, but nobody looked to see where the blood was going. And it was a slow ooze from the wound, and they were just wiping the neck. When we took the patient to theater, the HB was 6, and all the blood was literally under her back. So she was bleeding around and it was just trickling down her neck and pooling under her back. So she had at least about a liter of blood under her back alone. So you always make sure you get cross match done for these patients, right? Because they're going to drop their AHB. Then when you get into theater, the ideal situation is you have to decide what type of tracheostomy that has been done. Has it been a percutaneous trache or has it been an open surgical trache? You want it to be an open surgical trache because literally it's about speaking to your anesthetist to control the airway. You need to get a tracheostomy tube out. You need to get an endotracheal tube in because that's the only way you can explore that wound properly. If it's a percutaneous trache, it's a more difficult scenario because you need to open up that wound. You have to make sure you can control and get with your tracheostomy inside you and get to the point of where they've done their tracheostomy tube insertion and make sure you have an airway that can be visualized, because if the anesthetist can't intubate from the top, you have to be able to keep a tracheostomy tube in from below. So that's where it gets a bit more difficult. And then after that point, so the easy part comes, which is trying to find the bleeder. And then you can put things like flow seal, TIS seal, bipolar diathermy to your bleeding edges. These are the sort of things that you can do. But the main issue with these patients is getting an adequate surgical view while securing the airway. And in my opinion, the best thing to do is get your surgical view and then ask your anesthetist to intubate from the top. Because once the patient is off to sleep, they can have a look from the top and see what type of airway it is. And once they can intubate the patient from the top, you go in, tell them, take your tracheostomy tube out, get their endotracheal tube in, and you're good to go. You have a nice open field where you can have a good exploration around. There's no messing around. If you hit the tube, it pops out of place. You can barely see. You can't see the edges of your tracheostomy on the tracheal window, all these sort of things. And that's my opinion on that, basically. So summary for that.
So you prefer during the surgical exploration to intubate the patient, by the anesthetist, then
Yeah.
have a good view to the surgical trache.
Yeah.
Because sometimes the anesthetists are not happy to do something like that. I know maybe you agree with me, but this actually will give the optimum. I agree with you, the optimum
Yeah.
exploration.
So
So
if
you
they're
see
not,
the one.
yeah, what I do, I tell them in that situation, listen, can you put a Mach 3 blade down, or, one of the video laryngoscopes down, see what kind of view you have, see if you can pass a bougie, pass your bougie down. Once you hit the tracheostomy tube, keep the bougie in place, right? So that means that they're in the airway, they have a good airway. I will keep the tracheostomy tube in view, and then we do an airway exchange at that point. So they mount the endotracheal tube onto the bougie, and they railroad it down. And once they hit the tracheostomy tube, I take the tracheostomy tube out, and then they continue down with the endotracheal tube. It is a faff, but at the end of the day, you don't want this patient to have to come back to theater 2 hours later because they're still bleeding. You've not done a proper exploration. Or two, you are in theater for 5 hours. I know someone knows what I'm talking about. Fudging
Yeah.
around a around a tube that's just obstructing your view. You can't see what's going on. It's all
Because
about
it may be from
preparation.
the thyroid, could be from the thyroid
Correct.
gland itself, good bleeding or anything like that.
And you're just messing around and you're hoping for the best with a tracheostomy tube in the middle of your neck and you're trying to find a bleeder. It's not worthwhile.
Yeah. And in case if it's a cancer patient, for example, and the airway is obstructed from above, maybe also the other option to put an endotracheal tube through the tracheostomy opening. Do you agree with that as
I
well?
agree.
Because the manipulation would be easier than definitely from the tracheostomy tube.
The issue with that would be, however, the reason it's easier to manipulate is the same thing that goes against you because it's easier to pop out as well.
Mm-hmm. Yeah.
So you can lose the airway easier by putting an endotracheal tube into a tracheostomy window opening. That's the problem with it. It's easier to manipulate, but you can easily lose that airway and you'll have your anesthetist panicking all the time. So in the cancer patient, that's why I always say with cancer patients, I go for a CT angio, and if there's a blush sign, you're asking for interventional radiology. If it's bleeding from a trache. Because you're much better doing that because you will have a big faff having a massive tracheostomy tube in the middle of your surgical view and you can't find the bleeder.
Mm-hmm. Yeah, that's your point.
I always try to get the airway as secure as possible from the top and then do what I have to do from below.
So just to sum up what you say, that if we get a call for a bleeding trache, we have to think first, is it something, while we're going to assess a patient, is it something related to medically or surgically? And after that, have a look into the tracheostomy tube about the size, see if you're able to identify the site of the bleeding, or it's just during the suction there is some bleeding coming with the suction, which is more toward the medical causes than the surgical cause. And assessing according ABC, as you said, checking the bloods as well, then determine if there is an active bleeding that's not stopped by any compression or anything to consider surgical intervention.
Yeah. And this is in the actively bleeding patient. I'm not talking about like blood stain secretions. And all. This is a patient who's actually pouring blood out of the tracheostomy stoma or through the tracheostomy tube. So those patients wouldn't really, it shouldn't really be a situation where someone has suction and damaged the mucosa or tracheitis. These are proper bleeding trachea patients I'm talking about, where they're just not stopping and it's a wrist block in the airway. You look down, there's blood in the carina, blood in each bronchi, that kind of situation. Yeah. And as I said, it's better to take 45 minutes to prep this patient to get an adequate surgical view. So you take 20 minutes to sort out the bleeding. Then you take 5 hours trying to faff around a tracheostomy tube, putting all sorts of TIS seal and what you call it, flow seal and all these things. But you're just hoping that you're basically throwing 100 arrows at a blind target. You don't know which one you're hitting. And there's a high risk that the patient will bleed again, or you might be lucky and the flow seal has actually settled onto the area which was bleeding and you get away at that point. But I always go for getting the tracheostomy tube out of the way if it's possible. That's my number one thing. I make that clear with the anesthetist from up front. And if they get nervous, say, I will talk you through. I will tell them, put a video laryngoscope, put a bougie down, make sure it hits the tracheostomy tube, and then railroad an ET tube down the bougie. And once it touches the tracheostomy tube, then I will take out the tracheostomy so that you know they are in the airway already.
Because definitely if the patients need to be taken to theater, so I assume there is actually a source of bleeding. It will not be a generalized oozing.
Correct.
It will be something, we have to find it.
Correct.
So
Correct.
otherwise he will not need to be taken to theater.
Correct.
So
Correct.
yeah.
Absolutely. That's the thing, Ken. If you have made the decision this patient needs to go to theater, it's significant enough that you need to do a proper exploration of that neck. You need to open the wound, have a good look around, see if it's your anterior jugs, see if it's your muscle edge when you split the straps, see if it's your mucosa from the tracheostomy, see if it's an aberrant artery from the thyroid that got nicked, something like that. Yeah. Is that all right?
Yeah. Thank you, Raj,
No
for
problem.
your nice presentation for this topic.
I just thought I'll make it short and sweet. It was last minute, but it's within the remit of head and neck hemorrhage. I think this is the most important thing for the exam point of view, and that's what you have to know. What I've told you is all that you need to learn. It'll help you pass the written and the practical part. So those main things that I've talked about, and a few tips to help you with intraoperatively.
Really helpful. Thank you so much.
Thank you. No
Thank you
problem at all.
for agreeing to do this last minute.
No, that's fine. That's fine.
Thank you.
No problem. All right. I'll catch you all then. Take care.
Yeah.
All right, bye.